Electrical stimulation techniques. We're going to start with a pop quiz. Name the type of electrical signal as represented by the examples on this slide. Are you ready for the answers? A is a continuous biphasic alternating current. This is an example of a sinusoidal wave, which is very common in therapeutic modalities. B is a continuous monophasic direct current. The current in this graph only stays on the positive side of the isoelectric line. C is a burst biphasic alternating current. There is an interpulse interval in this example. D is a continuous biphasic alternating current. This is an example of a box wave. This is the exact same example as example A. The only difference is the shape of the wave. E is a pulsed direct current. F is a pulsed burst direct current. This current has an interpulse interval between the bursts as well as intrapulse intervals, which is the off time between each pulse. G is a continuous biphasic alternating current. This is an example of a triangle wave. This is the exact same example as A and D. The only difference, again, is the shape of the wave. H is a continuous monophasic direct current. The current is the same as example B. I is a pulse direct current. This is the same type of current as E, just a different shape. In these examples, there weren't any ramping currents. All of these currents were balanced phases and were symmetrical. So, how did you do? Hopefully well. So, as a review of the practical example of the human body and its interaction with electrical stimulation, remember that the human body is essentially a mass of tissues and fluids. Remember on principle that the more water content, the better conductor of electricity the body tissue is. As the electrical impulse enters the body, it must first pass through the skin, which may provide a significant resistance to the electrical current and therefore is a poor conductor for electricity. Bone, tendons, fascia, and adipose are other poor conductors of electrical stimulation. After passing through the skin, the electrical pulse enters the fat, in which there is very little resistance due to high water content in the fat. Muscles, nerves, blood, and fat are all good conductors for electrical impulses due to high water content. Tissue within the human body are either classified as excitable or non-excitable. Excitable tissues are directly influenced by the current and have the ability to respond to the current, usually through a contraction, action potential, or increased cell membrane permeability. Examples of tissues that are excitable are nerves, muscles, and cell membranes. Non-excitable tissues do not directly respond to current, but may be influenced by the electrical fields caused by the current. Examples of tissues that are non-excitable are bone, cartilage, tendons, and adipose tissue. In order to have an effect, we must be able to excite excitable tissues with the use of electrical energy. Nerve fibers have a capacitance, which is the ability to store an electrical charge. If the current is more than the nerves can store, an action potential results very quickly. Large diameter nerves have a low capacitance or ability to store electrical charge. Examples of large diameter nerves are the A-alpha and A-beta nerves, which respond to touch and pressure, as well as the muscle spindle and Golgi tendon organ within the muscle. Small diameter nerves and muscles have a high capacitance or ability to store an electrical charge. Examples of small diameter nerves are the A-delta and C fibers, which respond to pain signals. With the ability to excite excitable tissues, there is what is called a strength duration curve. There is an association between the intensity of the current and the phase duration of the current, which will evoke different nerve impulses. A short phase duration requires a higher intensity. A longer phase duration requires lower intensity to stimulate the same nerve. The use of electrical stimulation for therapeutic purposes goes back a long time. This is not a new treatment within the therapeutic world. There are several physiological effects associated with the application of stimulation. At a cellular level, the application of electrical stimulation results in an excitation of nerve cells, change in cell permeability, usually an increase in cellular permeability, increases in protein synthesis, stimulation of fibroblasts and osteoblasts, and modification of microcirculation. At a tissue level, the application of electrical stimulation results in frequent muscle contractions, tissue regeneration, and increased tissue remodeling. At a segment level, the application of electrical stimulation results in muscle pumping action, lymphatic drainage, and blood flow improvement. At a systemic level, the application of electrical stimulation results in analgesic effects and improvement of overall circulation. These physiological effects can occur in two ways, either through direct effects or indirect effects. The direct effects occur along the line of the current flow. The indirect effects occur as a result of the physiological response in an area remote to the site of current flow. Electrodes are devices attached to the terminals of a generator or electrical stimulator unit, through which current enters and leaves the body. Electrodes come in a variety of sizes, shapes, and materials and are named according to their function. There are many types of electrodes: polymers, metal, carbon-impregnated silicone rubber, and self-adhesive, among other types. Electrodes introduce the current to the body. They function as a medium needed to decrease resistance. The electrodes are attached to the body through a lead, which is the pathway from the modulator to the human body. The three most popular electrode systems over the years have been metal sponge electrodes. A thin metal plate attaches to the wire from the terminal. A wet sponge is placed between the metal plate and the skin to increase the conductivity between the two. These are held in place with a flexible rubber belt or a sandbag. 2. Carbon or silicone impregnated rubber electrodes with sponge, paper towel, or conductive gel interfaces. Carbon or silicone is added to the rubber, which is an insulator, so that it becomes a conductor. A wet sponge, a wet paper towel, or conductive gel is placed between the rubber plate and the skin to increase the conductivity between the two. These are held in place with a flexible rubber belt or a sandbag. Number 3, adhesive-backed carbon or silicone-impregnated rubber electrodes. Adhesive is used in place of a sponge or paper towel and a rubber belt or sandbag. These are quicker and easier to apply, but are more expensive than other systems. They were intended to be single-use disposable electrodes, but most people reuse them 8 to 10 times, or until the adhesive loses its stickiness. The one issue with reusable electrodes is that we have to consider the potential to have cross-contamination. Self-adhesive electrodes should be reused only on the same patient. If used on different patients, bacteria from one patient may be transferred to the next patient through the use of these pads. Electrode current density. The shape of an electrode is not important. Most of them are round, square, or rectangle. However, the size and the material that the electrons are made of are significant. The current density is inversely proportional to the size of the electrode. Occasionally, during electrical therapy treatments, different size electrodes may be used to either increase or decrease the current density among motor points and to activate certain areas of the body. As we increase the current density by decreasing the area of the electrode, We increase the stimulus, which means there is a greater potential for an uncomfortable sensation under the smaller electrode. The size of the electrode and its placement determine the number of motor units that are stimulated. A small electrode placed over a single muscle will stimulate only that muscle, whereas a larger electrode can stimulate a number of muscles. The size of electrodes also has a bearing on the current density under the electrode. The smaller the electrode is, the greater the current density will be as long as the current output is the same. The conductivity of the material of the electrode will affect the amount of current flow. Carbon or silicone-impregnated rubber electrodes seem to have better conductivity than do metal sponge electrodes, but their useful life is limited. The carbon or silicone will leach out with use, reducing the electrode's conductivity over time. Electrode placement can have an effect on the treatment of patients. A monopolar electrode placement occurs when one small active electrode is used with a larger dispersive pad. An active electrode is a smaller electrode under which the current density is great enough to elicit a desired response. A dispersive electrode is a larger electrode under which the current density is not great enough to elicit a desired response. An electrode is dispersive when it is much larger than the electrode or electrodes from the opposite terminal. It is used to complete the circuit and is usually applied to a location remote to the area being treated. A bipolar electrode placement occurs when there are two equal-sized active electrodes. A quadpolar electrical placement occurs when there are four equal-sized active electrodes. With a monopolar electrode placement, there is a small active pad that is placed over the target tissue. Sometimes this active pad is bifurcated, which means the lead gets split into two even smaller electrodes to surround an area. A large dispersive pad is used to complete the circuit and is usually placed away from the target area. Often the patient does not perceive current under the dispersive site. The most common current type would be a monophasic current. Remember, monophasic current is a pulse with only one phase. The current flows in only one direction. Bipolar pad placement is another option. A bipolar pad placement occurs when you have two active pads that are equal in size. Remember, we are not talking about bipolar being a psychological condition. Rather, this is an electrode placement setup that can be modified for our patients. This is a commonly used method in TENS or transcutaneous electrical nerve stimulation. Either a monophasic or biphasic current can be utilized with a bipolar pad placement. The patient should report equal stimulation under each electrode placement. The typical protocol is to sandwich the painful area or treatment area so that the pads are not directly on top of that area. Rather, if you drew a straight line from one pad to another, it would run directly through the area you want to treat. A quadpolar electrode setup requires that there are two sets of electrodes that result in four equally active electrodes. This setup is commonly used with interferential or IFC treatment. IFC is one of the most common electrical stimulation techniques utilized in therapeutic clinics. With a quadpolar setup, it results in three-dimensional configuration of a current. Interferential current is unique as the two currents actually affect each other, and the resulting interfered current results in the treatment of the tissues. In this example of a quadpolar setup, we can see the two leads. We have the two pads from A, which is lead 1, and two pads from B, which is lead 2. These two currents interact with each other, and the difference between the two currents is what actually treats the tissues. If a clinician or a therapist is attempting to target certain tissues, they may want to identify either motor points or trigger points. Motor points are specific points in the body where motor nerves and blood vessels enter a muscle mass. When motor points are stimulated, it will result in a muscle twitch. There are multiple charts to locate common motor points in the human body. Trigger points, on the other hand, are pathological. They are localized in areas that are hypersensitive to stimulation. When trigger points are stimulated, it will result in radiating, referred pain. There are also common trigger points within the body that we can consult via tables. If a clinician is trying to locate stimulation points, either motor or trigger points, it is very important that the clinician has a solid understanding of the musculature and underlying anatomy in which they are attempting to treat. It is imperative that a clinician be able to identify muscle origin, insertion, and fiber direction in order to properly place electrodes. The electrodes must be placed along the direction of the muscle fiber. Do not place the electrodes perpendicular to the muscle fiber, as it will have no effect on the muscular point you are attempting to stimulate. On occasion, a clinician may need to try out electrode placements and then relocate the electrodes based on trial and error. A clinician will also have to determine the electrode proximity by determining how deep your target treatment area is. With the electrodes closer together, this is a relatively shallow treatment, as there are few parallel paths for the electrical current to occur. By placing the pads further apart, the number of parallel paths increases, which should in theory result in a deeper treatment. The patient will tell you that the focus of the treatment stimulation becomes less defined. For some clinicians, spreading the electrodes further apart causes concern, especially when electrodes crisscross the spine. Some clinicians will refuse to crisscross the spine with electricity for fear of stimulating the spinal nerves with a deeper treatment area. Of course, this is just a theory. In all reality, electricity is going to travel along the path of least resistance. While this picture has a demonstration of a fairly deep penetration of electrical energy within the quadriceps muscle, this is not actually the way the body works. To date, there are no documented cases of any spinal damage, injury, or even stimulation with the application of superficial electrode placement around the spine. The simple fact that electricity will follow the path of least resistance, which is going to be at a superficial level. In addition, the depth of the spinal nerves and the protective surrounding soft tissue and bony tissue make the spine a relatively low risk. However, it is completely up to the clinician to determine the treatment that they are comfortable providing. There are 4 primary levels of stimulation within therapeutic electricity. Treatments can occur at a subsensory level, with examples such as MENS or microcurrent. A microcurrent electrical neuromuscular stimulator, or MENS, also known as a microamperage electrical neuromuscular stimulator, is a device used to send weak electrical signals to the body. Such devices apply extremely small, less than 1 microampere, electrical currents to nerves using electrode placements on the skin. The patient cannot feel the treatment, and there are no nerves that are activated. Treatment can also occur at a sensory level, with examples such as TENS, or transcutaneous electrical nerve stimulation. Sensory level stimulation occurs as a result of stimulation of sensory nerves, either alpha or beta fibers. Treatment may also occur at a motor level, with an example of Russian current. Motor level stimulation occurs with the activation of motor nerves and will result in a visible muscle contraction. Treatment may also occur at a noxious level. However, this is not nearly as common of a treatment due to extreme discomfort. This treatment results in a brief, intense, acupuncture-like transcutaneous electrical nerve stimulation. Noxious level stimulation occurs with activation of the nociceptors, the A delta and C fibers.